Welcome to The Explainer. Today we're doing a deep dive into systemic antifungal agents. We're going to move through a pretty systematic analysis of how we select them, how we apply them, and of course the challenges that come up, especially in our more complex patients.
You know, this quote really gets to the heart of it. This idea of matching the agent to the pathogen, the right key for the right lock, is pretty much the central rule in antifungal therapy. It means you absolutely have to have a detailed grasp of both the bug susceptibility and the drug's pharmacology to get those positive clinical outcomes we're all aiming for.
So here's how we're going to tackle this. Our agenda follows a logical clinical workflow. We'll kick things off with the core principles of selection. Then we'll review the key drug classes. After that, we'll get into the nitty-gritty of application and dosing, cover the risks, and wrap up with the growing challenge of resistance before a quick knowledge check.
Okay. Let's start at the beginning with some foundational advice. Sticking to these core principles is absolutely critical, especially when you're navigating those high-risk scenarios where, let's be honest, the therapeutic window can be incredibly narrow.
Really, effective management boils down to a couple of key things. First, it's all about teamwork. You absolutely have to consult with an ID specialist and a medical microbiologist, particularly if you have any suspicion of azole resistance. And second, you've got to be proactive. For patients who are on antibiotics for more than a week, you should be thinking about prophylactic antifungals to head off any opportunistic infections.
All right, next up, let's take a look at our primary therapeutic classes. Think of this as opening up the main toolkit we have to work with. We'll outline how they work and where they fit best to build a solid framework for using them in the clinic.
The azoles, they're really a cornerstone class. You've got Fluconazole, which is often our go-to for stepping down therapy in candidemia and for those tricky sanctuary site infections, like in the eye, because it just gets there so well. Then you have Voriconazole, which gives you that broader coverage against molds and is still our first-line choice for invasive aspergillosis.
Now, the story of Amphotericin B is a really great example of pharmaceutical evolution. The conventional deoxycholate form, well, it's just brutal on the kidneys, which has made it pretty much obsolete for systemic use. But then came the lipid-based formulations, and they completely changed the game. Their safety profile is so much better, which lets us use effective doses against really nasty infections caused by things like Cryptococcus and Zygomycetes.
And this brings us to the Echinocandins. These have really become the established first-line therapy for invasive candidiasis in most adult patients. So picture this. You have a critically ill patient, you're suspecting candidemia. You're probably going to reach for an agent like an Anidulafungin for that initial empiric treatment, especially because you know it has reliable activity against Fluconazole-resistant species like C. glabrata.
Okay, so picking the right agent is only half the battle. You have to pair it with the correct application. This next part is all about the key principles of dosing and strategy, everything from loading doses to de-escalation.
So, loading doses. They're all about getting to therapeutic concentrations fast. You want to hit the infection hard from day one. That 70 milligram loading dose of Caspofungin, for example, is standard practice for a reason. It ensures you get adequate drug exposure right from the get-go.
This de-escalation pathway is just a core principle of good antifungal stewardship. You start broad, right? Usually with an echinocandin. Then you reassess after about 5 days. Is the patient stable? Are the follow-up cultures negative? And importantly, is the isolate susceptible? If you can check all those boxes, then it's time to switch to a narrower agent like Fluconazole to minimize that selection pressure.
Okay, so right in the middle of all this dense data, the source material actually included this. I feel obliged to share it.
All right, back to it. We have to talk about the risks that come with these agents. Now we're going to focus on those tricky drug interactions and the important considerations for special patient populations. Drug-drug interactions. This is a huge area of concern. Rifampicin is just a classic example of a potent P450 enzyme inducer. It can literally chew up azoles like Voriconazole and spit them out, dropping their levels to sub-therapeutic concentrations. It just highlights why a thorough medication review is an absolute must for every single patient.
So for certain drugs, therapeutic drug monitoring isn't just a suggestion, it's the standard of care. Azoles like Voriconazole and Polyenes have this really significant pharmacokinetic variability from one person to the next. That makes TDM absolutely essential to make sure drug levels are in that sweet spot. the therapeutic window, to maximize efficacy and minimize toxicity.
You know, our therapeutic choices have to be carefully considered depending on the patient in front of us. In children with invasive candidiasis, for instance, Caspofungin and Micafungin are the preferred agents. And it's so critical to remember that Anidulafungin isn't licensed for pediatric use. It's a perfect reminder of why you always have to check the agent-specific prescribing info.
And finally, we turn to what is becoming an escalating challenge for all of us: antifungal resistance. It's an evolving threat that's constantly undermining our therapeutic efficacy.
The source material makes a really compelling and, frankly, sobering point about where some of this resistance comes from. It suggests a direct line between the agricultural use of azole fungicides in the environment and the emergence of clinical resistance we see in pathogens like Aspergillus fumigatus. It really frames the problem as an ecological one that has landed squarely in our clinics.
And this resistance crisis is not a single problem. It's multifaceted. You have increasing panazole resistance in Aspergillus. You have emerging issues like reduced susceptibility to Echinocandins and Candida parapsilosis. And then you have the really significant urgent threats posed by multi-drug resistant organisms like Candida auris.
Okay, we've covered a lot of ground. To help make some of this stick, let's just run through a couple of questions that test some of the key concepts we've talked about.
First question for you. Which antifungal is basically useless against Aspergillus terreus because of intrinsic resistance?
The answer is Amphotericin B. This is one of those critical, species-specific facts you just have to know. If you're dealing with Aspergillus terreus, therapy needs to be azole-based because Amphotericin B is clinically ineffective.
And the final question: what's that essential monitoring parameter for optimizing the use of agents like Voriconazole?
And the answer is, of course, therapeutic drug monitoring. Just like we discussed, that significant interpatient variability makes TDM absolutely essential to ensure both the safety and the efficacy of these powerful agents.
So this really brings us to the central challenge, doesn't it? The landscape of fungal infections is not static. As these pathogens evolve under all sorts of selective pressures, our diagnostic tools, our therapies, our stewardship strategies, they all have to evolve in lockstep. The critical question we have to leave with is this: how will our practice adapt to stay ahead of this threat?